All right, up next, we have Dr. Kate Levok. She is a research assistant in the School of Pharmacy and Pharmaceutical Sciences at Cardiff University, UK. Together with Gamma Healthcare Limited, Kate is developing novel formulations to combat bacterial biofilms formed on hospital surfaces in healthcare settings, notably dry biofilms. She finished her PhD at Cranfield University, where her thesis focused on development of novel technologies for microbial biofilm cultivation. Her research interests include formation and development of microbial biofilms and control of healthcare-associated infections from biofilms.
Good afternoon. Firstly, I would like to thank Dr. Christine Green for giving me the chance of speaking at the very first HITS conference, but I think she just left. Before I start, I wanted to disclose that I'm working for both Cardiff University in Wales and Gamma Healthcare in England. And Gamma is a company specializing in infection control. So my presentation is divided into 3 sections. So the first one is about biofilms in general. For those of you who are not familiar with the biofilm concept, I will give a definition of biofilm. I'll be talking what are biofilms formed of and how they are formed. Also, in the second section, I'll be talking why biofilms are actually problematic. And the last section is about fighting biofilms. So I'll give some policies and guidelines that are in place indirectly related to biofilms. And also I will be talking about the work that we are doing in Cardiff University regarding fighting the biofilms. So what is biofilm? Biofilm is basically a film of microbes adhered onto the surface, and cells are secreting so-called extracellular polymeric substances and form a sort of a 3D structural matrix. Most of microorganisms are capable of forming biofilm, for example, bacteria or microalgae. So here on those 3 scanning electron microscope images you can see from the left, bacterial biofilm formed on leather chair, and the remaining 2 are microalgal biofilm formed on stainless steel and polystyrene plastic. And this microalgal is Staphylococcus species. So what they are formed of, the biofilms? So as I said, they are formed of cells, but not entire biofilm is formed of cells. The other constituents are DNA and RNA, polysaccharides, proteins, but mostly water. I thought that would be much easier if I show an animation of how biofilm is formed. So here is how it is formed in spine disc implant. So when the bacterial cells are approaching the surface of the implant, they are reversibly adhering to the surface, overcoming repulsive forces. And at the beginning, there is a lag phase, after which the cells start to multiply. So-called irreversible attachment takes place, and cells start to secrete extracellular polymeric substances. So the whole biofilm grows, and due to the EPS, there is a nutrients exchange and DNA information exchange, and basically biofilm maturates. When the biofilm is becoming mature, in deeper layer of the biofilm, cells are metabolically inactive, and basically when the biofilm is approaching the end phase of its life, some of the cells will leave the biofilm in search for a new nutrient sources. So there will be either in the form of a fragment detachment, as you can see on the left, or cells will leave the biofilm in the form of planktonic shower, will be looking for a new nutrient sources. So they want to adhere onto new surface and form a new biofilm. So you might already seen some biofilms. Regarding the colonization environment, we can divide them into aquatic biofilms and dry biofilms, about which is this presentation. So aquatic biofilms, as the name suggests, they are the ones that are formed in liquid environments. So you might see them as microalgal biofilms formed on ships, or bacterial biofilms in the form of dental plaque. Aerial biofilms are the ones that are formed outside the liquid environment, and you might see them as microalgal biofilms forming on building facades. However, not all the biofilms can be seen, but naked eye. So when you think on some items present in hospital settings, basically after the standard decontamination and doing a visual audit, you see that everything looks perfectly clean. To check whether the environment is free of microorganisms, most of the hospitals use swabbing, so they use a cotton swab and streak over the surface of the items after the contamination, and then incubate the cotton swab to see whether there are any bacteria. However, it was shown that even after the decontamination, biofilms are still present on the surface. And this is what we also checked in Cardiff University. We decontaminated the surfaces and we checked by swabbing whether there's any bacteria present. We found nothing, but then when we took those surfaces under scanning electron microscope, we found an evidence of bacteria biofilms. Some of them are quite small, so only few cells present on those items. Some of them are whole communities of bacterial biofilms. So at this stage, you might think that maybe they are inactive, and this is what we thought. But then we incubated those items after, as I said, after the contamination and after checking by swabbing whether there is anything of them. And we plated them on selective agars. What we found out is that at least one species present on every hospital items. So here there are only few ones that we tested. There are much more. And basically on every of them we found some bacteria. Also, so we found mostly Staph aureus, but also there was some MRSA, some Acinetobacter, and we confirmed it by DNA analysis. So why is there a problem? You are all aware with healthcare-associated infections, and it was estimated that around 65% of those infections are correlated to biofilms. So what is the main cause of healthcare-associated infections? So basically there are a few factors that might impact those kind of infections. For example, frequent relocation when there is a lack of beds at hospital and patient needs to be moved. Also invasive procedures causing patient to have lower immunology system. And environmental conditions such as bad cleaning practices and, for example, food debris present, those factors contributing to the development of healthcare-associated infections. And especially this last factor, environmental conditions, they influence, they impact the development formulation of dry biofilms. And transferability is the biggest problem when we think of dry biofilms, because when the bacteria can be moved between the surfaces due to the transfer, it increases the risk of healthcare-associated infections. The other problem is that biofilms are really hard to kill, much more difficult than the cell suspensions. Why is it so? Bacteria in biofilm can communicate due to quorum sensing. So they can form, secrete EPS, form 3D communities, which make them much more harder to be penetrated. Thus, they have a high antimicrobial resistance. Also, the other problem is that as they maturate, the biofilm becomes stronger, and also they require higher contact times of disinfectant to be killed. And we actually, in Cardiff University, we tested. We had wet biofilm and dry biofilm, which we developing in our lab, and I will tell you more in a second. So we used 3 common disinfectants, so glutaraldehyde, paracetic acid, and chlorine. And we check how much bacteria can be reduced from the wet biofilm after the treatment. So almost around 2 log reduction was achieved for wet biofilm. And when we treated with dry biofilms, we achieved much less. And there are some policies in place. In UK, they were issued by Public Health England or Public Health Wales. In US, the Healthcare Infection Control Practices Advisory Committee is giving guidelines and advice indirectly related to biofilms, because they are giving guidelines regarding the cleaning procedures and for example, how to properly insert the catheter. So they have enough effect on the biofilm formation as well, indirectly. However, the problem is that these visual audits are not actually reflecting the infection risk at the site. As I showed previously, when you see some items in the hospital, they look perfectly fine, but when you check them, there are bacteria biofilms on them. And also the important part of it is that up to 1/3 of healthcare-associated infections could be avoided if the cleaning practices were improved. And regarding the dry biofilms, the other problem is that there is no standardized test for testing dry biofilms. In European Union, there is no test for any kind of biofilms. In US, there are some tests for wet biofilms. And even companies are reluctant regarding this problem due to the high costs and really high complexity of biofilms. In Cardiff University, we tested the commonly used disinfectants in hospitals. And unfortunately, we obtained a regrowth after 1 day in all of the cases. So basically, the other aspect is that we need some stronger disinfectant to treat dry biofilms, as they are more resistant than the wet biofilms. And so we developed a model to form sort of a dry biofilm. So the model is like we are growing Staphylococcus on stainless steel discs, and we are growing them for 12 days in wet-dry cycles. So in a wet cycle, the discs are inoculated with Staphylococcus culture and are placed on rotary shaker, and for 2 days they're spending in wet conditions. But then after those 48 hours, they are drained out from TSB and moved to the incubator, and they spend another 2 days in dry conditions. And those cycles continue until 12 days of growth. So the biofilm that we were able to achieve is more uniform than the hospital samples. Obviously, there is still a problem with reproducibility of the test due to the nature of biofilm. There are so many factors that are affecting biofilm growth and formation. However, it's much better than the hospital samples that we were working on. So this model ensures us high reproducibility of data in comparison to the surfaces that we are getting from hospitals. And they are more resistant to the disinfectant than the wet biofilms, as you might see on previous slides when I presented a chart with the data. And so we are performing disinfectant tests to check how much bacteria can be killed. So we are using HTM test, and basically we are placing a disinfectant that we are testing on the wipe, and then wipe the disc with the Staphylococcus biofilm, artificial one, from both sides, because the bacteria are able to adhere and form biofilm against gravitational forces. So we need to use 2 wipes to wipe from both sides. And after the wiping, the discs are placed into empty well plate where disinfectant action is allowed. So usually we use 2-minute contact time. After this contact time, discs are placed into neutralizer to stop disinfectant action. And so here are our results. We tested the most common disinfectant used in hospitals. We couldn't give the names. So the reduction of bacteria. As you can see, there is really high variance in the results. As I said, with biofilms, there are really high problem with reproducibility of data. In the case of those last 2 formulations, there is no variance because they were killing all of the bacteria. But the problem is, even in the case of those effective formulations, we are facing a few days regrowth. So basically, so far, there is no formulation that is killing the entire biofilm. So that's what we're working on. And the most important thing here is transmission, because we are interested of how many bacteria can be transferred 1 day after the disinfectant treatment. So as less is the best. And as you can see, water was used as a reference, so it's almost 100% transmission. And some other disinfectant commonly used in hospitals, there was also showing some transmission. And this is what after 1 day, after more days, it's even higher. So the model that we are using still needs improvement, basically because we want to have higher reparability of data. But the most important part here is that it will match in resistance to hospital samples. So here I will show some data comparing artificial dry biofilm model that we use in Cardiff University with hospital samples that we are getting from UK hospitals. So when you look at the transmission, the almost 100% transmission takes place only in case of water and sodium hypochlorite 1000 ppm, which are the weakest disinfectant in comparison with the remaining 3 ones. However, in the way of hospital samples, there is 100 transmissions in all of the cases, except the last formulation. And the regrowth, so this is a number of days that take the biofilm to regrow after the treatment. So the lowest is the worst. Obviously water, there is a regrowth after 1 day, and with weaker disinfectant, sodium hypochlorite, it's 2 days. It's more than 10 days for the stronger disinfectants. However, when we look at hospital samples, the regrowth is really fast. The only exception is the last formulation. However, as I said, there is still regrowth. So we are not killing the whole biofilm. So sum up, basically there is a problem with hospital surfaces because we found on every of them, we found some bacteria biofilms, even after the contamination and even after when the swabbing is showing that there should be nothing. So the other problem is swabbing, that it needs to be changed because the method that hospitals are using so far, it's not effective in showing whether the cleaning was effective. And we were wondering whether there's a link between dry biofilms and the URO infections, because the patients that are entering the room after MDRO patient, they have really high risk of getting MDRO themselves as well, even after the standard decontamination procedures. So as we think of dry biofilms who are really resistant much more than the cell suspensions or wet biofilms, that might be the suspect in this case. So I really want to thank Professor Raif for his support, Diane Ripost for her help in the lab, research and development team of Gamma, and any other person which are involved in this project. And thank you very much for your attention. I think it was really fast.
Hi, so you mentioned that when you were testing the environment prior to checking for biofilm, you use a traditional method of using a Q-tip with saline and then culturing that, right? Do you know anything about ATP testing that's done in hospitals? Do you know whether ATP testing would show the biofilm or not? Whether it would detect it?
I'm not aware of this test, unfortunately,
okay.
Sorry.
Thanks, Dr. Ledwak. Great presentation. We appreciate you sharing your formula. Do you know the general class of disinfectants in formula D and E by any chance, or general chemical category?
Sorry, I don't know. Yeah.
I can say in our experience, ATP counts don't correlate to microbial counts based on growth cycle, nutrient conditions, a variety of other things.
Hi, Kate, thank you very much. Just to respond to the ATP query first, it's Jimmy Walker from Public Health England. ATP will just detect protein. So it will not tell you whether that's bacterial protein or amoeba protein or any other protein that's on the surface. You would get a high result from just swiping your hand. Yeah?
Sure. But it's still not clear whether that would show you whether there is biofilm or not. Let's say if the ATP testing is showing low counts of protein, does that mean that protein would represent biofilm or anything?
Any protein.
So it's safe to say that if ATP is passing the minimum or maximum counts for a certain area, it's safe to assume that that was appropriately disinfected?
So generally speaking, you generate a baseline after a cleaning procedure. You set that as a clean standard, and then you go back and perform your cleaning procedures over time. If you're above baseline, you need to re-clean. It's just a cleanliness measure for the ATP counts at that point. So it's not correlated to bioburden, just organic matter that's present that would have ATP, which is any living cell. So it's a good proxy in the event where you can't culture for microorganisms.
What is it about what is it about dry biofilms? Why are they resistant? What is that mechanism?
Because they need to survive in harsher environments. Basically, they don't have a current supply of water and nutrients, so they need to make themselves resistant in order to survive. And also, as I said, in deeper layer of the biofilms, they are metabolically inactive. So when there is some disinfectant action, like the disinfectant which are acting on alive cells, then they might avoid this kind of action. And yeah, and also they are strongly embedded within extracellular polymeric substances, which make them even more resistant. So there are so many factors put in together that are affecting that resistance. Okay,
and just one final point. You seem to be wanted to search for a product that's going to completely kill the biofilm, which I find that's going to be very, very challenging for you. Surely it's going to be, you're going to have to look at the surface, think about the cleanability of the process of cleaning it before you give me a disinfectant, because only then you'll get a better challenge.
Yeah, I know it is a challenge. So maybe it would be better to find a disinfectant that is having the higher regrowth, days of regrowth. So basically some routine cleaning procedure might be, for example, repeated every week or so. So yeah.
Hi, Kristen Vanderelsen from University of Michigan. Thank you. I wondered if you've tested any other surfaces different from stainless steel discs. For example, it might be a wet biofilm question, but in flexible endoscopes, we're obviously they stay wet, and of course there's biofilms in them. But I wonder that is to me a really big hot topic for biofilm research in medical care is plastics and their ability to grow biofilms, and what types of plastics are less likely to do that, and if there's any coating you can put on them. Those are all really interesting to me.
Yeah, we started our research on stainless steel disc. However, now currently we are growing biofilms of different kind of plastics, so PP, PETG, PVC. We are growing biofilms on ceramic as well, so to mimic the hospital items. So yeah, we will have a data on that soon.
You mentioned that swabbing is not an effective way of detecting dry biofilm. Are you trying to look at any other methods that could be used to detect dry biofilms in a healthcare facility? Something that's practical enough to check a surface to see if there is a dry biofilm present after disinfection?
Yeah, this is our current challenge, to find some rapid detection tool that basically can show us whether there is a biofilm or not really quickly. So this is what we are also currently working on. So far we haven't started with any experiments, but yeah, this is what we have in mind. So this is what we're also working on.
Hi, thank you very much for your presentation. You did an excellent job. I have a question about whether you've looked at any alternative disinfectant technologies against biofilm growth or regrowth, so UV light or any fogging systems.
We did a VHP treatment and it didn't work that well, to be honest. With some disinfectants here we could achieve 6 or 8 log reduction, whereas VHP treatment gave us only 4 log reduction. So we are looking into other types of treatments. But with biofilms, especially the ones that I'm growing as a dry biofilm model, the problem is that the cells are adhering to both sides of the disc. So for example, for VHP treatment, obviously it should reach the whole disc because this is a vapor, so it's acting on the whole surface. And still, it is not able to kill all the bacteria. So I guess some treatments might need to be improved if we want them to kill dry biofilms.
Sorry, I seem to be weighing in on just about everything today. So I just want to make a comment on the ATP. I think because the extracellular contents are a polysaccharide matrix, you wouldn't expect to find ATP there to be measured in that matrix, especially when you're using the flimsy swabs. You'd have to actually get down in. And you've got the the bacteria in a dormant state, a non-metabolic state anyway, and so essentially their ATP machinery is not in a very high functioning state. But you would get the same false negatives there as you would get from the cultures from just doing a swab on the surface, I would think. And to that, some of the presentations I've seen at some recent conferences, they've really looked at changing the way you're doing the cleaning, so focusing on elbow grease, microfiber, et cetera, in addition to the disinfectants specifically. And I know if you use a common device like a wiperator where you've got consistency in your testing, there's a very important variable there that I think we're missing on how we could potentially address this. Two other points, I think, looking for a gold standard for testing for biofilms. I know there's a couple of different companies right now who are looking at imaging systems, and I can't speak too much because they're not commercial at this point, but you'll be able to actually image, or just like you use a scanning electron microscope to see the bacteria, something that's not as, down to that level, but something where you could actually detect or image a biofilm on a surface. And then the final thing was ozonated water is being used in the beverage industry, in the pharmaceutical industry, and now the dentistry industry, specifically for wet biofilms. And there seems to be some thought that it could be applicable to dry biofilms as well.
One of the things, I've done a lot of work with water contamination, and we'd be just all of us would be shocked if we knew what was in an ice cube or what was in the dental water or even the endoscope processing machines that Kristen had talked about. So one of the things that we've been rather successful for, and I see the industry responding to that, is peroxide products. I think you mentioned VHP.
Yes.
But VHP, again, unless you're using the one that forms a condensation on the surface, might not be as effective as the other two types of delivery. So one of the things that we see is that the peroxide has done incredible things to keep dialysis systems free of biofilm. They effervesce it off the surface. So I'm really curious, given the right kind of compatible material, glass would be ideal, but we don't use it. And it's because of its tendency to leak. But some of those kinds of things with peroxide, I think, still need to be explored, especially a persistent peroxide on a surface. Dry surfaces, I'm curious about dried biofilm. I'm curious about if you can't take it off with a swab, what makes you think it's going to jump onto a person. So again, I'd appreciate a comment on my last comment regarding if you can't swab it off, what makes you think it's going to transmit?
You mean how I'm checking the trans?
Well, you take a swab and you say you can't detect it using the swab method. Well, if you can't get it off the surface with a swab, why will it leave the surface to make me infect me?
Yeah, I know what you mean. So you mean that if there is nothing on the swab, then it means that nothing can be transferred.
Well, it's best tendency to transfer because it's on the surface. You can do this to it, but if it's there, regardless if it's on a Kelly clamp, you clamp that onto a surface of accidentally touch a patient, will it jump? Will it make that move? We've got to think of the ring of transmission, the whole infection control chain of events that occur. What makes it jump if it can't come off the surface? There's got to be a mechanism like contact, continuous contact with that individual that may make it viable because the water's there. But I'm real curious about the dry biofilms and their ability to transmit disease.
Yeah, so the transfer is measured basically by at pressure contact against the neutralizing agar. And the other thing is that directly after the treatment, usually we are not having any transfer. The thing is that we need to incubate the samples before we get any kind of transferability. So this is the other thing, that when the surface is decontaminated, strictly after the contamination, we are finding nothing by swabbing, and also there is no transfer. But one day after that, when the sample rests, then there become a transfer visible, and when we do the transfer test, we have almost 100% transferability. So this is also interesting thing about biofilms, that they can have some small amount of time to regain themselves. So, yeah.
Thank you. So I just wanted to comment to the gentleman in the back regarding transfer of biofilm. It's my understanding that in certain situations, for example, when you have an invasive device such as a central line catheter, where you could potentially have biofilm growth on the hub or port where you access with the IV catheter, so you could actually transfer the biofilm into the vascular system and bloodstream and cause an infection. And it's my understanding that that's the purpose of alcohol scrubbing with the wipe, as opposed to just alcohol as a disinfectant. There's also the component of mechanical removal of the biofilm. So I think maybe that kind of addresses that question.
All right, thanks everyone. One more final hand for Dr. Ledvolk.